Good.
And you?
Good, thank you. Good. I think we're
Ah,
live on YouTube now. It says I've got a little notification.
Are we?
Yeah.
Yes.
Just about to go live.
Right.
And in fact, would you mind, Nicole? Oh, we're not going to go live yet. No one's going to see it.
Okay.
All right.
But the link will be live. Just about to go live. Oh, we are live. And in fact, would you mind, Nicole? Oh, we're not going to go. That was the feedback. Nicole, do you mind?
Yes. Paul, for you, we're breaking the illusion that we're not in the same room, same house. So I'm going to go to the other room and help Nick with the live stream.
Right. You too.
I think this is live now. Then bit's
But
recorded.
no one's seeing it. So
But we'll need to edit
need
it
to
out.
edit it.
Okay.
How are you disseminating this? I mean, after you've recorded it, how do people know about it?
So a full recording is on the BOBAB website, which we incorporate within an event summary doc, which is sent out to all the attendees and lots of other people as well.
Send one to me, will you, so I can forward it to Wilton Park.
Yeah, we'll do.
I'm really glad about that appointment because it gives us lots of opportunities, actually.
About what, sorry?
You know, I've been appointed to the advisory board of Wilton Park.
Well, yeah, I noticed when you responded to your bio.
Yeah.
But so that's a recent thing, yeah?
Yeah, just a couple of weeks ago.
Oh, fantastic. Well, yeah, they're a really interesting organisation.
So I'd be quite interested to sort of link yourselves and Medicus up to their health people so that you're on their list, as it were. One, so they can take your feed, but also so they can involve you and Nicole in work that Wilton Park is doing around health, public health in Africa and beyond.
Oh, great.
Because
interesting.
They'll be doing a major piece of work on post-COVID, lessons to be learned and so on.
Oh, great. That would be really good. Thank you.
Sorry, did you embed the...
Yeah, sorry, I just wanted to make sure it wasn't on there. Okay. All right, that's done.
Thank you so much.
Are we still private? Or can everyone hear us?
Yeah, we're private for the time being.
Okay. When's the baby due?
11th of October.
As we're private. Oh, how exciting.
Very. He'll get to meet Lord in his first few years, hopefully, if this is all over.
Yeah, Janet and I can't wait to meet them.
Oh. My dad keeps reminding me that this is your life now. It's going to be very difficult. That's his advice.
Your dad is absolutely correct. It's a lifetime responsibility, believe you me.
Yeah, I mean, we're still their responsibility even as adults. So it's
exactly.
a lifelong thing.
Okay, we're about to go live, at least on the. So I'll give it. I'm gonna let this other speakers in, and then we'll go live in a moment.
And can I talk to the other speakers like I did last time?
Yeah, of course.
Great.
Hi.
Hiya.
Hi, Nick. It's Tari.
Hi, Tari. How are you doing?
Good, thanks.
Excellent. Paul, Tari is one of our speakers based in Zimbabwe, doing some really, really interesting work there. And I think we have...
We're looking forward very much to hearing from you, Tarisai.
Thank you, Paul.
And I think we have Bright as well. Hi, Bright.
Hi, Bright.
Hi, hello, how are you?
I'm well, and you?
I'm good. Am I clear?
Yeah, we can hear you loud and clear. Thanks.
Okay.
Bright, just a quick question. Are you able to share your presentation from where you are?
Yeah, so I'm trying to I'm getting on my computer in like 3 minutes. So I'll be able to share.
Okay, perfect.
Funny enough, it started for some reason. Today is the day it started to update. You know, crazy.
Okay. Fair enough. It happens sometimes. Okay, I'm going to share the live link soon and we'll start having participants in soon. So I'm going to temporarily share my screen, which will have the speaker's profile on it, just so everyone knows what's going on. And then when we're due to start, I'll stop sharing the screen, Paul, and we can get going.
Yeah, I'd like to say just a few words when all the speakers are together about timing.
Yeah.
And keeping everyone, we're doing it for, everyone's got 10 minutes, right?
Yeah.
Good. I just like to stress the importance of keeping to time to everybody when we're all gathered.
Of course, yeah.
If you'd give me a moment to do that.
Yeah, no problem.
Linda's not with us yet.
Not yet, no.
Neither is
Jean.
Nick.
No, neither is Nick. Jean, just a quick one. Are you able to share Linda's presentation from your computer? Because I haven't got it through yet. Jean?
We're starting in 5 minutes. So plan B to go straight to Tarisai if the other two aren't with us.
Yeah, yeah. If that's okay with you, Tari.
Tarisai, Tari?
Yeah, I'm here. Yeah, I'm here. I'm trying to share my screen. Nick, is that okay?
Yeah, you don't have to do it just yet, but if we're Linda, who is due to speak first, isn't joined by one, we'll go straight to you, and then Linda can join after, can go afterwards. If that's okay.
Okay, no, that's fine.
Nick, I've got Linda's slides now as well, so if I can screen share if we need.
Okay, great. We're going to go live pretty soon, guys.
And you'll let me know when I should start, will you?
Yeah.
Okay, I'm joining with my computer shortly in a minute.
Okay.
Nick, on the chat, we just had a message from, I think one is Nick Bass asking how to join the session. Might be worth popping him an email with the link.
Yeah, we'll do. Just one sec.
Tarisai, even if Nick joins us, I'm coming to you first because I think the first word must come from Africa. So if Linda's not with us, we're coming straight to you.
Okay, no, that's fine. Yeah,
Thanks a
sure.
lot. Thank you.
Sorry, Nick. I'm just following up with Dr. Linda, but I see Nicole's got her slides, so let me just quickly follow up with her on the link. Hi, everyone.
Hi.
Hi.
Right, it's 1 o'clock. Nick, Nicole?
Yeah, very nearly to go.
No Linda Jean?
I got her. She said she's just joining. I can't see her.
I have her slides up and ready when she is. But as Paul said, I think we'll start with Tari now anyway.
I
think
think
we start.
Can you send it?
bear with me one sec. Sorry, everyone. I'm just looking into an admin thing. Just bear with me, Paul. I'll get back to you in a minute or two. 1 second.
Okay.
Oh, there we have Dr. Nyamute.
Hi, Linda, welcome. Hello, Linda, welcome. Dr. Nyamute. Dr. Nyamute, Linda, can you hear me? Dr. Nyamute, can you hear me?
Yes,
Linda?
I can hear you. I can hear you now.
Welcome, excellent. We'll be coming to you, I think, third. We're
Okay.
starting with Tadisai, then going on to Nick, if he's here. If he's not, we'll come straight to you.
Okay.
Great. And I was saying to everybody, one of the things we do is we are very strict about time. So
Yes,
everyone's
sorry.
got 10 minutes, and
10 minutes.
I keep everyone to that.
Okay.
Great. I love your background, Linda. Is it real?
No, it's a wallpaper.
It's real. It's wallpaper.
It's a wallpaper. It's a wallpaper.
Wow, amazing.
Thank you.
That's incredible.
Yeah. It gets a lot of attention. I know. Yeah. Michael.
Our parliament now in the UK is virtual. So we
Ah.
all contribute virtually. So we've been given strict instructions to have neutral background. So I've got this boring gray thing behind me.
Do I need to change mine?
Yes.
You want me to change mine? I can change it.
No, it's lovely. No, I love yours. I only wish that I was allowed to have something as interesting. No, don't change it.
All right.
Bright, are you based in Nairobi?
Yes, I'm based in Nairobi.
Oh, great. How are things there?
Things are looking, I mean, the situation is I would say better than we expected.
Is it? Good.
But yeah, in terms of the numbers and COVID-19, but financially for most people, it's becoming a problem each day.
Yeah.
Yeah.
That's what I hear. I chair a project called Water and Sanitation for the Urban Poor. And we work in 7 African countries and in Bangladesh. And we have an office in Nairobi, and we're working in a number of cities in Kenya. As the title would suggest, it's for the urban poor. And we hear things are pretty tough at the moment for them.
Sure.
Okay, Paul, apologies for the slight delay there. There was a slight technical blip with the event link, but we've remedied that. So, and I think all our speakers are here. We've been joined by Victor and Nick. Hello to you both. So ready to start when you are.
Hi, Victor and Nick. Just one word before I start. It's 10 minutes strictly for everybody. Just please bear that in mind. You look forward enormously to your contributions. Okay, Nick, tell me when you're ready.
Ready,
right. Okay. Which Nick? Sorry, there are 2 Nicks.
Hi, Nick. I'm Paul. I'm moderating Nick's date. But we're coming to you, Nick, second. So
Okay.
first of all, then you, and then Linda. And then Bright, and then Victor. Okay?
Sure.
Good.
We're ready to go, Paul.
Good afternoon. Good afternoon and welcome. My name's Paul Boateng, and I'm moderating this second in the series.
Paul, apologies for the slight delay there. There was a slight technical blip with the event link, but we've remedied that. So, and I think all our speakers
somebody needs to go on mute because they're playing the video.
So ready to start.
Hi, Victor and Nick. Just one word before I start. It's 10 minutes strictly for everybody. Just please bear that in mind. You look forward enormously to your contributions. Okay, Nick, tell me when you're ready.
Oh, right. Okay. Which Nick? Sorry, there are two.
Hello. Good afternoon. My name's Paul Boateng, and I'm chairing this second in the series of COVID-19 Exchange. We are here in the eye of the COVID storm, and we're looking together, practitioners, people working out there in the field, under the auspices we come together of BOBAB and of Medicus, and you'll be hearing more about them later. But the focus of our work is to enable in conversation the exchange of practical ideas, practical information, learning together what works, what doesn't, what we can do to make a difference at a time of crisis. This is Mental Health Week, and mental health clearly has huge implications. There are huge mental health implications from the virus, both for patients, for their carers, for clinicians, and for all who work in this area. Real stress, real pressure. And we'll be looking at some of the responses to that with a distinguished panel, and we're glad to have them with us. Just some ground rules as to how we work. We're keen to maximize the number of you who can participate in this session. And that means I'm going to be very strict about time. It's helpful too if you would mute yourself if you're not speaking, to prevent some of the technical blowback issues which we've all been experiencing during this time. Also, and importantly, don't hesitate to put your hand up metaphorically on the Zoom system to indicate through chat if you've got any questions. And we aim to take a couple of questions after each speaker. And then at the end, we will come back for a plenary session in which we can all contribute. And remember, we're looking to make a difference. This is about being prepared to think outside the box. It's about recognizing some of the practical issues that we face, not least on the continent of Africa, as we deal with this crisis. Always important too to bear in mind the context. In Africa, we have what, 1.4 mental health workers for every 100,000 of our population. Compare that to the rest of the world, where there's a global average of about 9 workers for every 100,000 of the population. So we have our challenges, but Africa is a resilient continent. Africa is an innovative continent, and we're about exploring the innovation that can make a difference, not only in Africa, but to the World Wide Web, and through the World Wide Web to the world in coping with this global pandemic. So without further ado, I come first of all to Nick State of BOBAB, just to give us his take about BOBAB's participation in this. And then I'm going to go to Nicole Kaunde, in order to share with her what Medicus is doing in response to the crisis. Over to you, Nick.
Thank you, Paul. Hello, everyone. First of all, apologies for the slight delay. We had a technical blip with the event link, but I'm glad to see the vast majority of people are joining us, and we'll be letting more people in as the event progresses. But just a very quick introduction from me. As Paul mentioned, my name is Nick State. I'm the CEO of BOBAB. We're an event streaming and peer-to-peer networking platform dedicated to connecting science, tech, and business professionals working in and for Africa. We exist for a simple purpose: to accelerate science, tech, and innovation happening in and for Africa. And we do that by working with partners like Medicus, to host events such as this, where we work to make it easy for experts like those on the webinar to come together, to connect, to explore challenges, to promote initiatives and innovative solutions, and ultimately to enhance collaboration. That's how we think challenges such as COVID-19 are going to be addressed, is through collaboration. And I'm really, really happy to be co-producing this series with Medixus, who are doing some fantastic work on the ground, connecting medics and doctors. And yeah, this series was designed to do exactly that, provide a space where we can come together to explore the many challenges, to hopefully share learnings and experiences, and also crucially to promote best practice. There's an awful lot of noise around COVID. We want to be a positive contributing voice in sharing ideas and sharing perspectives. So that's what today's about, and I encourage you all to contribute where you can, and hopefully take something really positive from today. Thank you.
Thank you. Over to you, Nicole.
Thank you. Hi, everybody. As Nick and Paul have both said, I'm Nicole Kayode and the founder of Medixus. We're really excited to be bringing you the second in our 4-part webinar series. At Medixus, we focus very heavily on knowledge sharing between medics. As Nick and Paul have both said, I'm Nicole Kayode and the founder of Medixus. I think it's Celia, maybe, to go on mute. Thank you. And there's a bit of a housekeeping thing, I guess. Everybody, if you can, make sure that you are on mute. I know it happens, but if we make sure we're on mute when we're not speaking, then that would be great. So yes, we are bringing this together because we all know that mental health is a huge thing, that it impacts people at the best of times in their day-to-day life, let alone in these extreme circumstances we all find ourselves in now. So as healthcare workers, how can we encourage our clinicians to protect their mental health, because what they're seeing is often unprecedented, and they're being asked to treat in circumstances that again are pretty unprecedented, as well as the mental health of patients. So from first-hand experience, patients struggle with maybe being in ITU and sedated for many weeks, and then coming to wake up and having to terms of what's happened to them. So this is a really platform. Thank you. This is a really interesting platform for us to try and explore some of those wider issues, and share some practical tips with each other about how we can combat and overcome some of the mental health challenges that we as a world, as Paul has pointed out, are going to face at this time. So yes, and another reminder for those watching us via the live stream on YouTube, through the Bobab platform, there's a live chat over to the right, so feel free to post your questions in there, and equally those of us here with us on Zoom, pop your questions in the chat or raise a hand if you'd like to speak, because it's all about knowledge sharing, so we invite you to do so. Back to you, Paul. Oh, Paul, you're on mute. You took the being on mute cue too well.
Thank you very much. We're all about at COVID-19 Exchange about hearing voices from the front line, voices rooted in experience. And we're very lucky today to have with us Tarisai Bere, who is a registered clinical psychologist. She's a global mental health specialist, a behavioral science lecturer. She's working in Zimbabwe, not least in ensuring that psychological interventions are culturally appropriate. She is a former Friendship Bench trainer and supervisor. She currently works as a senior clinical psychologist for the Tendai Project at the University of Zimbabwe College of Health Science. We're really pleased to have you with us today, Teresa, an authentic voice from the front line. Do share with us your experiences.
Thank you. Thank you, Paul. Okay, so I'm going to be presenting our work on behalf of the Mental Health Task Force for COVID-19 for Zimbabwe, and I've been working with the Ministry of Health and Child Care, Department of Mental Health. So I've got slides. I don't know, Nick, if you can show my slides, or if I'll be able to share.
Sorry, Tari, are you able to share your screen directly, or did you want me to share for you?
Either way, it's saying that host disabled participant screen sharing.
Oh, really? Let me just check that.
Another technical difficulty. This is Zoom. Zoom's updated security settings coming to irritate us.
Okay.
Bear with me 1 second, and I'll pull up your slides.
Great. They're up on the screen. Over to you, Tarisai.
Thank you. So like I said, I'm presenting this on behalf of the Mental Health Task Force for COVID-19. So just to give you a bit of a background, next slide. A bit of a background about Zimbabwe. Zimbabwe is a sub-Saharan African country. It's a low-income country with a population of about 16 million. And really the unemployment rate is quite high, about 95%. So only 5 people are formally employed. So yeah, the lockdown really means that people are not working as they should. Next slide. Okay, and just maybe to give you a bit of a background on the major public health concerns we've had. Mental health is a problem. We have high rates of depression, 1 in every 4 adults. And we also have high rates of HIV. And in adolescents, between the ages of 15 and 24, the rate of depression is at 51.7. Next slide. Okay, and to date, we have, talking about COVID-19 now, we have tested close to 29,000 people. 46 people have tested positive. 18 are recovering, 24 are still active, and we've had 4 deaths. And most of the people who've been tested have had a history of travel, and the local transmissions have been mainly from contacts of the people who had traveled. We are now on what we call level 2 of the lockdown. The first level was when we were locked down completely, but now the industries have opened, which means that people have started going back to work. But it's just a small percentage of people going back to work. Most of the people are still under lockdown, as most of the people are informally employed. Next slide. Okay, so the common responses that we've seen, while other countries, people have been scared about the virus itself, here in Zimbabwe, people have been really scared about losing livelihoods. So the lockdown meant that you're not going to work anymore. Those people who work on a day-to-day basis just to make money enough for a plate of food at the end of the day wouldn't be able to do that. So that's been scary. And people have said that they are scared of dying of hunger more than dying of the virus. So one of the major stressors, next slide, has been losing livelihoods because of the extended lockdown. So we started off with 21 days, and now we're in this level 2 of lockdown, but on an indefinite period. So it's going to be reviewed after every 2 weeks. And yeah, really people are not being able to provide for food and, security as well. And the other thing that we've noticed has been that the people who are traveling back into the country could be citizens or just maybe people who were trading between countries have been quarantined for 21 days. And one of the major sources of anxiety has been lack of communication when they are tested, and then they're waiting for their test results, and then maybe just having enough information to know when they're going to be released to go back to their families. This has caused major anxiety in isolation facilities. Looking more into our healthcare workers, we obviously have, like many other countries, the issue of lack of PPE. And this has really caused a bit of discomfort in our healthcare workers. And then now that children are not going to school, parents are worried for those few who are going to work now, worried about leaving their kids alone. So we've seen a lot of gender-based violence increasing, and then we're also very worried about the children and adolescents who have to spend the day at home unmonitored. Next slide. Okay, so the common mental disorders that we expect to rise in Zimbabwe are obviously anxiety, because we've had high rates of anxiety and depression. And we're also anticipating that post-traumatic stress will increase. We've seen an increase in substance use and suicide. So as a private practitioner, while I hardly ever get suicide alerts, this week alone I've been getting close to 5 calls a day of suicide alerts from different people. So we're learning from other countries just to look into the common mental disorders that we might need to look out for. Next slide. Okay, so what we've done in terms of management has been to go back to the mental health and psychosocial guidelines that have been provided by the Interagency Standing Committee. And we've tried to provide information about COVID-19 just to ease the fear and the misconceptions, and just to give people a lot of information so that they are empowered and they know what to do and what not to do. And we're trying by all means to get the healthcare workers PPE, and obviously now looking into issues of stigma for those who've tested positive, and just trying to also monitor what you're doing in terms of mental health and psychosocial support, so that when the dust settles, really we might have information about what worked and what didn't work. Just maybe next slide. A background on the major public health concerns we've had. Okay. Mental health is the problem. So what we've done so far has been to use social media because of the lockdown. So we've created a lot of videos that address COVID-19 and the fear around COVID-19, how to know that fear has gone into anxiety, and if it's become anxiety disorder, what to do and who to call. So we have a lot of mental health practitioners who volunteered to get training in basic psychological first aid and problem management class. So this ranges from our psychiatric nurses, social workers, occupational therapists, psychologists, and psychiatrists. So we've got funding for that training. It's going to go on next week so that we at least have people who are trained in identifying mental health issues and at least have a know-how of how to deal with someone who might be completely scared or might have anxiety and depression because of COVID-19. So we've also tried to look into different populations, really, because of the high rate of HIV. We are tailor-making psychosocial interventions towards people who might have health anxiety, who might have, comorbid conditions. And we also looked into trying to tailor-make interventions for the elderly, for adolescents who are now not in school, and the healthcare workers. So this is all on our social media platforms. We've called it Sound Mind Zimbabwe. So replacing fear, anxiety with a sound mind. In the communities, we've always had the friendship bench, and they've taken up more of an intervention into COVID. So as far as the primary healthcare facilities and more community level is concerned, we have the friendship bench helping with that. And all of this has been so far virtual, telecounseling, and just videos and information resources everywhere on our website and our social media platforms. Next slide. We've covered areas like just looking into stress, anxiety, depression, the signs and the symptoms, just making people understand what causes them, and just maybe looking into how all of this is might actually be connected to the fear that might be coming from COVID-19. And we've provided calming techniques. We've also looked into substance use awareness and provided tools for people to understand that this is not just drinking on a day-to-day basis, but it's become a problem. And like I said before, we've provided support for the elderly, and we've connected with organizations that provide help for those who might be locked down with perpetrators of violence, so that they can find shelter and more help than we can provide on telephone, and information for people living with HIV, and more bereavement, because in the Shona culture, funerals are very important. So if someone dies, you have to go there, you have to comfort your loved ones, shaking hands, hugging, and all of that is part of the rich culture. But now that people have been limited in numbers of how many people are allowed to attend funerals, and you have to call people instead of going there and hugging them, it's been difficult. And we've seen a lot of complicated grief when people die, but we haven't really had lots of deaths that are COVID specific. It's just your usual deaths in the families. Yeah, next slide. And what we're planning ahead, we really want to treat mental health as a priority. And we are looking into, like I said before, training mental health practitioners in all provinces, so that each facility, each health facility has someone catering for mental health. And we want as many people as possible. So far in our port, we have about 200 people nationwide who are willing to get the training and to lead in different provinces. We have about 10 provinces.
Thank you very much indeed.
Okay.
Yeah. And give people an opportunity to ask any questions, and perhaps you can elaborate on the plans as they do.
Yep. Thank you.
Thank you for that very comprehensive presentation. Question. Right. Any hands up? Yeah. There's a question from Nasibu. How can we reach people in remote villages or communities where communications are difficult, and presumably there's no ready source of mental health practitioners or volunteers to actually provide support and assistance? How do you reach them?
Okay, so what we've done is to liaise with people from different provinces, even in the rural areas. So we have mental health, they could be mental health nurses or mental health doctors from different areas that are going to be providing mental health support. So these people are going to be trained as part of the package that we're providing.
Thank you very much for that. Thank you, Nasibu, for that question, and we'll broaden out the discussion as the afternoon progresses. I now turn to our, thank you very much indeed. I now turn to our second presenter, Dr. Nick Bass. Nick is the Director of Global Health at the East London NHS Foundation Trust, a psychiatrist by background. He set up the first UK NHS mental health focused global health partnership between East London and Uganda. So he brings an experience of working in and with Africa and African practitioners. He's also worked in Somaliland, Sierra Leone, and Kenya, supporting partners there, as well as establishing a program in Bangladesh. So truly a global practitioner. Over to you, Nick.
Thank you, Paul, and thank you, Nick. Like the previous speaker, my ability to put slides on has been disabled. So Nick.
Oh, we should have updated it. Have you? Can you try again? Because it should be working now.
It says host disabled screen sharing.
My apologies. Okay, bear with me 1 second, Nick, and I'll pull it up.
While Nick's doing that, if I can remind everybody, do use the chat column. That's working all the time. It's live. Don't hesitate whether you are on the phone or whether you are on the web. Let us know your questions and we'll feed them into the conversation. It's also worth saying that an edited version of this event will be out on the World Wide Web later on this afternoon as a resource. And the feedback from our first webinar indicates that it's found to be very, very useful. So all participation, all contributions, most welcome. Nick, how's it going?
Just one moment, Paul. Sorry, just pulling it up now.
We've got two Nicks. You can never have enough Nicks or enough Pauls. Okay. Todise, while we're waiting, I've got a question for you, Todise. Can you hear me? Todise, I've got a question for you. I mean, how do you, as an independent private practitioner, how do you relate to the government health service? Is there a government-funded public mental health service, or I mean, how does it work?
Okay, so we do have public hospitals that provide mental health, and we also have, like here in Harare, we have a crisis support center that's just specific for psychological intervention. So yes, the government does have mental health support. Right,
thank you very much. Fine, the slides are now up. Dr. Bass, Nick, over to you. Nick Bass, can you hear us?
Sorry, I was on mute again. Right, beg your pardon. Thank you, Paul. Thank you, Nick, for the kind invitation. And although I might sound like a global practitioner, I'm sitting here based in London at the moment, so not going very far at all right now. Yes, just to give you all a short overview of things. Slides. How do I move the slide forward? No, there we go. I work for the NHS, and just for those of you who don't know, we have a network of what are called global health partnerships between various NHS organisations and various countries, low and sometimes middle-income countries, mainly but not exclusively in sub-Saharan Africa. And a very nice summary of this is described in Nigel Crisp's excellent book on all things global health that I would thoroughly recommend to those of you who haven't seen it yet. So we cover a number of things, and we're usually doing on-the-ground training during short trips or occasionally longer visits over several months. But right now, like everybody else, we are rather stymied by the fact that international and even local travel is really not possible. So we work mainly in Uganda, but we do have a partnership in Bangladesh, and I've done a lot of work with Somaliland and Sierra Leone, which are projects run by King's College here in London. And so all our usual work has been put on hold. Let's do the next slide. Thank you. So East London, we cover the boroughs of Tower Hamlets, Hackney and Newham, but we've also got other parts of the UK now. And we've been working in Uganda for just over 16 years. And that's a picture of the main, well, the only national referral hospital for mental health patients in Uganda, called Butabika. And we often use the shorthand name, the Butabika link, to describe our work. But as I said, there are a number of other places that we support as well that are run by other colleagues. And I have to mention the fantastic Tropical Health Education Trust, who largely coordinate most of these partnerships between NHS trusts and other countries, and without whom we wouldn't really have been able to get started. So next slide, please. Thank you. And there's a snapshot. I'm sure this needs no introduction. I'm sure all of you look at this every day. The Johns Hopkins update on the spread of COVID-19. And as you can see, despite all the concerns about Africa, as a continent, it seems to have largely the lowest number of cases of pretty much anywhere in the world, which is perhaps surprising. Next slide, please. Thank you. So everything, everywhere, has been put on hold for now because of a single disease. And so it's kind of like the world has been suspended. And that leaves a big question mark over the SDGs, which again, I'm sure you'd need no introduction to, and where exactly we are heading with all of this, and in particular, mental health. Next slide, please. So I want to concentrate a little bit on this one. So Africa almost feels as though it's been left behind in all of this. First of all, there's a lot of concern that it may be about to face a massive avalanche of cases of COVID-19. And certainly Dr. Tedros at WHO has repeatedly warned about this. But there is the other possibility that COVID-19 becomes not only suddenly epidemic, but then becomes in the longer term endemic, and particularly across Africa. Again, this is another scenario that WHO is warning about. But as I said, COVID-19 is new to all of us over the last 4 months, and we mustn't forget all the other diseases that continue to blight Africa as well as other countries. So the non-COVID disorders continue, and there are also issues that Africa faces that are perhaps different or different in degree from other parts of the world, such as the risk of a traumatic lockdown. And I think we've already heard a little bit about that from Tarasai, and I would concur that some countries have taken this, have performed very stringent lockdowns indeed, which may be successful in the short term and possibly in the long term in controlling the virus, but will bring problems of their own. And food security is an issue that we have to remember is a major issue for low-income countries, most of whom will find themselves in sub-Saharan Africa. There's also the problem with shortages and access to health and medicines, and again, as Tarasai mentioned before, stigma. And this is something that doesn't necessarily affect people in Western countries to the extent it may do in poorer countries. Africa also has an additional special vulnerable group, as well as mental health patients, which are refugees. And one of the biggest communities of refugees anywhere in the world is in Uganda. And this is a community that have been struggling even before COVID-19. But one that I think we all need to remember is that we do not know what the future holds regarding this virus. And although we've been expecting a huge deluge of cases right across the continent, so far the total numbers are small compared to other places. And it looks like we may be facing a very long wait. Next slide, please. Thank you. There are some potential positives, though. What we've been working on, in the absence of being able to actually travel to meet with our partners in Uganda, is distance support. And I have to say, this has been fantastic. The engagement with shared and remote learning has been amazing. And a few months ago, who'd heard of Zoom? And yet here we are all using Zoom. And in answer to one of the questions put to Tarasai previously, this seems to work well, even with very remote locations. So here, for instance, is a community engagement session going on in one of the refugee settlements in West Nile district of northern Uganda. But we are even able to reach staff with poor signals via Zoom sessions, and it's been really, really helpful. The kind of training that we have been engaging in is online interactive training regarding management of suspected COVID-19 within mental health settings, which tend to be parts of the medical system which are neglected, under-resourced, and completely overlooked when it comes to planning for viral epidemics such as this. But that in itself is a great way of helping the staff with broad psychosocial support in getting them prepared and knowing what to expect. And this allows them to cascade that training on to other staff who've been unable to access the training, and also the wider communities. There's also the opportunity for local and regional networks to develop formally or informally, and for local innovations to take place. And I don't think we should underestimate Africa's ability to provide these. But I would say as well that whatever we think is appropriate to managing this epidemic situation in the Western world, and even according to WHO advice, appropriate public health measures need to be taken for the context of these low-income countries. And that regards measures of prevention, social distancing, which of course is incredibly difficult, if not impossible, in many of these places, appropriate testing, if at all, and also how to do contact tracing, as well as how to manage isolation of actual suspected or actual cases, as well as the psychosocial support. Next slide, please. I would also like to put in here something that I think is perfectly manageable and affordable for most of the world, and which tends to cause great controversy in Western countries and even within the WHO. And I don't really understand why. There looks like a pretty clear-cut case for this, and that is the wearing of masks. Masks do not have to be complex, expensive surgical masks. Anybody can make a mask out of an old t-shirt or a sock or something. And it's very clear that the countries that have had high rates of illness are the countries which culturally do not tend to involve wearing masks, whereas countries that have had low rates of illness down here are the ones that do wear masks when they go out. And I'm not saying this is absolutely going to prevent COVID-19 spread, of course it isn't, but it does look as though from the data here that it goes a long way to reducing the number of cases and the overall mortality, and would also mitigate the need for strict lockdowns when it is put in place. Next slide, please. And I'd also like to mention the key issue of poverty and what people in lockdown are expected to do in order to stay healthy, given that many of these people in sub-Saharan Africa will not benefit from any kind of social security support net. And if they don't work, they don't eat, essentially. And as you can see, most of the world's poorest countries are represented by these blue dots on Gapminder data, which is all drawn from UN data such as World Bank, WHO and such like, and they're virtually all in sub-Saharan Africa. But you can see, most importantly, that there is a correlation between income and health. And it is not an easy matter for people to just stop work, stay at home in order to prevent the virus going out. They will starve and be at risk of all sorts of other illnesses, as well as the risks of to their mental health and specific of domestic violence.
Thank you for that, Doctor. I wonder if you could begin to draw your remarks to a close.
Yes, of course. Next slide. I think we're all pretty much there, actually. So that's really the take-home message. And remember, most of sub-Saharan Africa will be on the left-hand side of this inflection point on the famous S-curve and stuck in the poverty trap, which is only going to be exacerbated by this. So I think there's a lot that we can do in Western countries, as the recently late Sir Fazle Abed, founder of BRAC, said, and even from our living rooms and workplaces in London and such like, we can do much to support our colleagues, even in remote communities. And that's it. Thank you.
Nick, thank you very much indeed for that. And thank you for the focus you put on getting responses that are culturally appropriate and also being prepared to learn from each other. I thought that the face mask slide was a particularly powerful one. And it's very interesting to note that recently, if you go onto the web and the various marketplaces, there's a whole industry now of African textile face masks, which are gaining ground here in the UK as well as in the US. So it's an interesting point you make. Now, questions?
We've had one question in the chat from Desiree, who has said, here in Burundi, the major concern is that the government is hiding COVID realities and no space is given to community actors to contribute to fighting the pandemic by providing mental health and psychosocial support. There's no lockdown, no curfew, and the presidential election that's upcoming seemed to be the government's priority. So we're expecting a hard situation in the coming days. As civil society, we need to try and find ways to help despite challenges. So I wonder if that's a bit of an open question to the floor. If I take the liberty of sort of turning that into a question, are there any ways that any of the speakers can think of that can empower civil society as well to support mental health within their communities?
I'm going to ask you, Dr. Nick, have you got any quick response to that? And then we'll hold the question and come back to it in plenary. Nick.
That's a tough one, and that depends on the individual countries. I guess we're fortunate in that the countries that we work with, as well as Uganda, have a rather different approach to things. But obviously I am aware that there are some countries where for political purposes, governments may be in denial about this or not wanting to respond because they fear it may, have an effect on their election outcomes, etc. It's a tough one. I think, Uganda, for instance, has shown remarkable approach to engaging, having communities engaging at a grassroots level in supporting mental health, even when resources are poor. And so does Somaliland, for instance, where we also do a lot of work. I
think that's a very important point, because if you think about Uganda, in the early stages of the AIDS pandemic, it was Uganda that gave us the slogan, "Love Safely," if you remember. And one of the things that Africa can do is actually to contribute to global messaging on these issues in a very effective way because of the African sense of community, Ubuntu. We are what we are because of. So thank you for giving us the example of Uganda and Somaliland, which is a country of which I happen to know of remarkable resilience, despite all its difficulties and challenges. There's a lot that we can learn from their responses. If we can now turn to continue the conversation to Dr. Nyamute, Linda Nyamute, who is a practicing consultant psychiatrist and mental health advocate based in Kenya. She has been doing some groundbreaking work with young adults and the challenges and difficulties that they often face. So over to you, Linda, Dr. Nyamute.
All right, I'll just begin by a small correction. It's Nyamute.
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 That's the African way, yes. You're pronouncing it the English way. The African way is Nyamute.
There's a reason for that.
All right, so with just mine is a very short presentation, sorry. So we can go to the next slide, please. Right, so that's just a brief analysis of where we are as a country, Kenya. Our total cases are slightly below 1,000, that's at 912. And our death rate as per yesterday was at 50 deaths from the positive cases, and we have a recovery of 336 patients. So as you can see, there's been a steady rise in the number of new cases per day that are recorded per day from one of the graphs there, as well as the deaths. Yeah. So just a brief outlook on the mental health profile in Kenya. This was a picture I took from one of our newspaper articles. So 1 in every 4 Kenyans has been diagnosed with a mental health illness. But this was a research actually done a while back. And 5 out of 6 Kenyans do not receive the treatment that they require. This is what we have on the ground at the moment, mental health, COVID aside. And 4 out of 5 people who commit suicide are usually from a very severe illness, particularly very severe mental illness, particularly depression in this case. And currently we have about just over 100 psychiatrists in practice at, just like every other country, as you mentioned, Lord Paul, when we were beginning, was we have mental health challenges in terms of our human resource. Yeah. Oh yeah, and our current population stands at 47 million, just to put that out there. Can you go to the next slide? So I'll not want to repeat what my fellow presenters have spoken about previously, so I'll just highlight what we are facing as a country. So our biggest challenges for the pre-existing mental health cases, we have challenges with adherence to medication. And a lot of this stems from, as we know, or we may not know, for in Kenya, the current situation on the ground is Nairobi, our capital city, has been locked. There's no in or out movement except for essential services. So patients who would come all the way to Nairobi to get treatment or whatever mental health care provision from Nairobi are unable to do so. So we're having a bit of adherence because of the travel restrictions as well. Then we're also having acute episodes, and this can also stem from the problem with adherence to medication, the lack of getting medication, as well as there's a lot of stigma in terms of going to access mental health care in the facility because they're scared of getting COVID. So they'll wait until things are like blown out of proportion to appear for a review. Then for the emerging cases, we have issues to do with gender-based violence. There's been a slight rise on gender-based violence, even according to WHO, with this COVID pandemic. And when we talk about gender-based violence, we also have to consider the children in this case who observe the whatever violence is going on in the home, and we know trauma affects children a lot. So the gender-based violence can also stem from financial hardship because people have been confined into their homes. There's also just that confinement can induce a very stressful environment that may precipitate violence. And yeah, as we know, the effect of violence on the child can go on even up to adulthood in some cases. When it comes to substance abuse, we have challenges, particularly with those receiving methadone replacement therapy and accessing the clinics. As we said, there's been a lockdown. Nairobi, I wouldn't call it a lockdown, but there's restriction of movement. The other thing is we have the harm reduction services tend to reduce as well. I mean, we're all having reduction in a lot of resources. So people who would receive syringes and other harm reduction equipment are also facing a shortage at the moment. So there's also stress drinking in terms of staying at home and being in a stressful environment. So a lot of people find themselves being in a position where they are taking alcohol more than they normally would. Then the vulnerable groups, we have the elderly. Because we've been restricted to visit them, they may be faced with a lot of loneliness, and we do know loneliness in itself can be a big risk factor to developing depression and dementia, worsening dementia amongst the elderly people. Then the children, of course, we have the restriction again, they're not in school, so there's reduced interaction with their peers and reduced play. And we know all these are important for the development of the child's brain. Then, of course, simple things like a missed birthday for a child means a lot. So they're not understanding why they can't have a birthday like everybody else. Then the changes in routine. And for the older children, we also have anxiety about the national exams and whether they'll do them, whether they'll not do them. Then that can also precipitate some sort of depressive episode. Then, of course, we have the teenagers and the adolescents, especially the young girls, may be predisposed to getting teenage pregnancies. Pregnant women have also, it's a very vulnerable state because some of them would normally have depended on their peers, their friends to come and support them once they deliver, to just see the baby and interact with them and provide some sort of psychological support, which is not present at the moment. And I don't know about other African countries, but for us, they usually do this pre-delivery sort of parties, which are not currently allowed at the moment, which also can be a bit stressful for first-time mothers and not knowing what to expect. Yeah. Then, so the general population, we also have the extroverts who are used to being outside and now being restricted, the introverts who are used to having their own space. The spaces have now been jammed up with the extroverts being confined at home. And of course, now things like weddings, as our first presenter mentioned, weddings and funerals have now been confined to very few people. And I mean, as our culture, these are usually events that gather masses of people during the gathering. So, and of course, now we can't forget the healthcare workers as well as a very vulnerable group who need the PEPs, the protective equipment, and there's also a challenge in accessing that. I think that is spans out among a number of African countries, and dealing also with the death of the patients, the healthcare workers who are on the front line to just handle and break that news and deal with that death process as well. So currently, moving forward, currently as a country, where we are at Kenya, what we're doing, there's a mental health task force, just like in Zimbabwe, where we're having trainings to just increase the number of healthcare workers, mental health care workers who can provide these services to scale up the treatment, or rather what is this? They can just scale up the provision of care, yeah. Then we also have, there's our collaboration with the WHO to the mental health gap. There should be an ongoing training as well. That's just to bridge the mental health gap and train non-skilled or non-professional healthcare workers to provide mental health services down to the community where they may not easily access healthcare. Yeah.
Thank
So,
you very much. Would you like to just round up?
Yes, please. So the other, so that is now what we have currently, and then we also have our mental health online platforms, and we continuing to offer the psychiatric care that has been there from before. Then moving forward, our challenges that we need to probably think about is to mitigate the current challenges, that particularly to do with the elderly, the children, as we talked about, the challenges that are there and just how we can curb them moving forward. And then, post-COVID, there's also the issue about transitioning back to work and back to school after all this is over, particularly because stigma for those who have been tested positive and just being isolated from the community, just the usual stigma, mental health stigma, then there's a COVID stigma, then the burnout, because we've been so used to working at home, and now transitioning back to work where you have to be work from 8 to 5 may also be a challenge. Yeah.
Thank you very much indeed for that and for those important insights, Dr. Nanuti. We've got a question, and I wonder if I can put it to you in this way. What are the lessons that we can learn from Kenya's HIV/AIDS experience in terms of mental health support that is cost effective and that helps fight this issue of stigma, which you've returned to on a number of occasions?
I think sorry, just repeat your question. What are the
lessons we can learn from Africa's response, Kenya's response to the HIV/AIDS pandemic in terms of addressing this issue of stigma and support for people who are suffering from the condition, but also people who are treating it?
I think our biggest resource would be awareness. As they say, information is power. So even with the HIV/AIDS, the main thing was just to continue education, the community education, tell them that this is how it is spread, and this is how, if you're infected, this is the treatment. You will not, you can still take medication and live for a long while. And then after a while, people started to actually accept that this is.
And who is doing this in Kenya? Is it just the government, or the churches, the private sector, actually doing this community health education program messaging?
For COVID, currently we have, of course, the government, but we also have mental health advocates. We have mental health champions all over the country. So they're the ones also championing for this.
Who's doing the churches?
The churches as well. Yes, for COVID or for HIV?
Yeah, for
COVID. Yes, the churches as well, but maybe not as much as we would want them to, would like them to. So if they put in, a bit more, we'd be really happy, because it's we are a very religious country as well. So the churches and the mosques as well will be very good platforms for the leaders there to also help us in spreading this information.
But I mean, I think it's very interesting that no presenter so far has mentioned the churches at all. And yet, until you, in response to my question. And the churches are the biggest single and most powerful institution on the continent of Africa, the churches and the mosques. So it's very interesting that just as in the early days of HIV/AIDS, the church and the mosques were silent, maybe now they need to step up to the plate. So thank you very much for that. We've got to move right. From Nicole. Look, are there myths around COVID-19, and how have those myths, if any, impacted on your responses to the pandemic?
Questions directed to me. I lost you a bit.
Yeah.
So the question directed to me.
From Umar, who's watching us on the live stream, who was asking if there are any myths in the communities about COVID and how that's impacted the mental health response. So this is a question to you and to previous speakers.
Okay, I think the biggest myth is in terms of how it's spread in the recovery, and you see how there's a lot of self-isolation that is required, rather quarantine when you are positive. So once they are out of quarantine, there's still a lot of stigma towards that will you still infect us, and people do not want to be near them because of the fact that there's already a thought that once you have COVID, you're walking COVID all your life.
Yeah, and what about urban myths? I remember with HIV/AIDS, they said, well, if you eat sweet potato, sweet African potato, if you eat, are there any of those sort of myths going around or not?
Maybe just to jump in and mention, what I've heard so far is that the African is immune to COVID-19. Why? Because heard stories about the chloroquine that we took with malaria, or just the African gene. So there's that story going around that Africans cannot get COVID-19.
Thank you very much indeed. Well, now is a good opportunity then to move on to our next contributor, Bright Shitemi, who is the founder of Mental 360, a non-profit organization that promotes mental health and awareness by raising the issue and focusing on the importance of support for youth in Kenya by providing innovative and relatable solutions using art, physical wellness, counseling, social support system. You know, the important thing about the work is that it targets the youth because they are seen not just as the most vulnerable in many ways, but also our future. So I wonder, Bright, if we could turn to you for your presentation.
Yeah, thank you, Paul, for the brilliant introduction. So I'll just jump into the COVID-19 mental health situation in Kenya. What we've seen so far is a lack of resources among many Kenyans to afford basic need items like food and also therapy for those who are going through mental health challenges. We've also seen by the fact that people are now physical distancing, a reduced access to treatment options. As Dr. Nyamute mentioned earlier, there is low literacy levels on mental health. Also, we've observed an increase in suicide ideation and attempts, and increased cases of sexual and gender-based violence at home. And the last thing we've also seen is an increase in substance abuse cases, with mostly people who are going through addiction issues relapsing. For medics, we've seen burnout among the professionals in the front line. There is, because of the lack of the PPE, increased stress and anxiety levels due to risk of exposure. The other thing we've seen is depression and PTSD among some professionals in the front line. So by the numbers, and I think also Dr. Nyamute went over this, is 1 in 4 Kenyans live with a mental illness. In the short run, we've observed many people relapsing. And long term, we see an increase in cases of mental health. The challenge being now to point number 2 80% of Kenyans with mental illness are unaware or do not receive treatment. And so with limited access to mental health care, this is going to be a number that's going to increase further. In Kenya, especially among the youth and all over the world, suicide is the second leading cause of death, with COVID-19 already occasioning a spike in suicide rates globally. So we've been running a helpline number, and what we've observed is 60% of the people calling in have experienced suicide ideation, and 55% of them have attempted suicide before. So that means 45% are people who are having these suicidal thoughts at the moment due to COVID-19. As I mentioned earlier, the resources we've had as an organization now is to have a helpline number. We also have a dedicated team of psychologists that is offering online mental health solutions via Zoom or WhatsApp videos, depending on the client's preferability. We also have partnership with public and private mental health institutions that can take in emergency cases. And another thing is that the main thing that's causing all these mental health problems we've observed is the lack of economic ability to even provide food for most people, especially in informal settlements. And so the last thing we're also doing as Mental 360 is we are organizing an online festival, which is an annual event we usually do to raise awareness on mental health. And for this year, we are doing an online version that is curated to focus on COVID-19 and mental health, and to provoke people to reach out, use art as a form of therapy, and on a global platform. Our recommendation to this situation right now is to, number one, amplify providers of mental health solutions, especially those who are offering digital solutions. For some parts of Africa at this moment, we're having digital health solutions. Apart from the telecounseling, we also have apps like in Kenya, we have Wazi and Inuka. So we should see more partnership with government to amplify these messages. And seeing as the number one reason for poor mental health at this moment is inability to provide food, which is the most basic item, would love to see more partnership with the government, NGOs, well-wishers, and corporate entities. In Kenya, we've seen a lot of private or individuals coming up to donate food items to people who are vulnerable. So more of this should be done. I think that's it for me. Thank you.
Well, thank you very much indeed for that. And thank you for being so disciplined in terms of time, because we are under huge pressure in that regard because of our earlier technical issues. I want us to hold on, if we might, to the point you made towards the end of your presentation, which was a fascinating one about apps. I mean, Kenya is outstanding in its apps industry, particularly in Nairobi, led by young people. And also importantly, the role of private philanthropy in responding to the virus. If we can hold those two things and come back to them, I hope, in discussion. But if we can now move on to the other side of Africa, to Nigeria, where again, we see a very exciting user-led response to the mental health crisis amongst young people. Mentally Aware Nigeria Initiative, Mani, has over 1,500 active volunteers and chapters in 18 out of Nigeria's 36 states. So we're very glad to have you with us, Victor Ugo, who is the founder of this particular mental health network, which is really trailblazing across the continent. So over to you, Victor. We're looking forward to hearing.
Thanks so much, Paul. I see we have like just little time left, so I'm just going to go straight to the point. Nigeria has more than 6,000 cases now confirmed. We have more than 1.6 thousand recoveries, and we have more than 190 deaths. We have botched a lockdown, and it's been lifted, even though we have rising cases. So we're just not in a good place at all. Regards to the integration of mental health into the COVID response, there's not been any integration of mental health into the conversation, and there's not been any recognition of it, in fact. But we know from our services and from I would say from our crisis support system that we've had an increase in number of people by 70% of people that reach out to us on our hotline. So we have a crisis support system which runs both using text-based support and also online hotline. Not just offline hotline. You get to call the numbers, and we've had more than a 70% increase in those people reaching out to us. And most of the recurring issues that we have seen is increase in anxiety, uncertainty about when the virus is going, when the pandemic is going to end, and we have had to rally in within ourselves to build the capacity to support those people. From our internal network of organizations that we have worked with on the ground, we and hospitals that we have access to, we have established that there's a very there's a lack of access to medications is a very huge problem for those with already pre-existing mental health conditions. And we know that psychiatric facilities are downscaling because they don't have access to PPEs, which means that they're not admitting new cases, and clinics are actually being downscaled, so they don't see as many patients as they would naturally see. And obviously, there's a case of people being afraid to go to those services to assess because of COVID. And we never, as Nigeria, we never had an established community mental health service anyway, which means that we have hundreds of thousands of people who are missing out on services that they would not normally have access to, even though rarely so. So as to how we are responding to COVID in Nigeria, we upscaled our crisis support system. So initially we had about 200 counselors on the ground who were trained to support anyone reaching out to us. And in the past 2 years, we've intervened in more than 20,000 cases. We had to open up a call for new people to join that we could train. So we started pretty early when the virus first got into Nigeria. We started training people for over 2 months, and we have trained 300 more people. So we have more than 500 counselors now, which is a good number to have, but still not enough because it still takes up to 24 hours before we can actually reach out to someone who reaches out to our system, our crisis support system. And apart from increasing the capacity to provide text-based counseling, we have dedicated lines for isolation centers across Nigeria. We have dedicated lines to healthcare workers to be able to assess for, because we know they're the ones at most pressure, and it takes a lot for them to pick up and go to work. And so we provided those special hotlines for them to call whenever they felt like it. And isolation centers, we made sure we are trying to make sure that every state in Nigeria has access to those numbers and provides them to people in those centers. We created a project covid.ng website, which has a lot of resources for people to use. We built a resource hub that covers how mental health and physical health are related, talks about what parents can do at home, what kids can do to cope with proper mental health, what people coping with domestic violence can do, resources for them to reach out to much more readily. And so that resource hub also has key messages translated into the 5 major languages spoken in Nigeria, and is being distributed widely. We're actually we're trying to work with the Ministry of Information to make sure that that's sent across to many people via SMS. And just as well, it's not just the key messages. Whenever we send those messages out, to make sure there's a call to action for numbers that they can reach out if they need support. And we have also, in a way, worked with the NCDC to actually more like advertise that, which not advertise, more like make sure that people got to see that if they needed support, they can actually access it through this non-profit. I think another thing else that we're doing is that we already have a large base of young people who work in our network. It's more than 1,500 people, young people that we are connected to. And now we are almost getting to 10,000 people because we changed the way that they would get, that they could reach out to us. So we created a community learning platform, which is on Telegram, and we have thousands of young people in various groups, and we organize weekly sessions that help them cope with their mental health or develop new, coping skills that hopefully they can find useful to them. But much more importantly for us, we feel like normally civil society organizations and NGOs, we start the fire, we don't fund the flames, and that's really down to the government to make sure that whatever work we are doing gets scaled to a larger population of people. So while we're starting these very small, programs and making as much impact as we possibly can, if we're really serious about reaching majority of Nigerians, we needed to advocate directly to the government to start to integrate mental health into their response. And this is something we're actively doing. So we by next month we are commissioning a research program that tries to understand how COVID has affected mental health. And with whatever piece we can produce from that, we can now make a case for, obviously increased investments by the government into mental health in its COVID response. As regards my recommendations, yesterday or 2 days ago, the UN launched a policy paper on COVID-19 and mental health, and gave three very clear recommendations that we are actually using as our key messages for the advocacy. And the first one is that we need to apply a whole of society approach to promoting, protecting, caring, respecting, and ensuring dignity of persons coping with mental health issues. And broken down, this is more like it's saying that obviously encourages integration of mental health into every sector, from educational sector to the health sector to social services and to communication. We need to make sure that obviously mental health is integrated into every sector, because that makes it easy for people to, I would say, develop better coping mechanisms to deal with the crisis, and also helps them to just it reduces it reduces the debilitating effect of the crisis on the mental health of the population. We know that because kids in the schools are out and kids are at home and people are accessing alternative learning approaches in Africa, we have a good mobile base population. A lot of people using mobile phones, but we haven't really done anything when it comes to data. We haven't achieved as much. So bandwidth is very low, and it's still difficult for most people who are out of school to be able to access learning opportunities online. I'm using Nigeria as a context. I'm sure some African countries are far ahead of this, but when you look at the population of Nigeria, we're not able to actually properly integrate or implement alternative learning approaches, and that's very difficult for parents. So obviously, this is something that government needs to look at, providing alternatives that parents can access and actually help them focus on their own work. And also now we there's a lot of talk about working from home. That doesn't really apply as much to our population, because we have a large population of small and medium businesses, and they can't actually do most of their work from home. And that's really what complicated the lockdown that we had, which didn't really work out well. And there's much to be said about making sure that the government provides and ensures transparent and clear communication, which paves the way for trust. One of the things that we keep saying is that we see conspiracy theories rise and go so far that people start to believe them, and that actually it reduces the kind of how people see the response to the virus and to the pandemic. And I feel like if the government was a bit more transparent and consistent, comprehensible, and had less threatening communication, that's something that we can avoid. The second recommendation here says to ensure widespread availability of emergency mental health and social support and programs. This just means making sure that even anyone in any population, older adults, frontline healthcare workers, people who have lost their livelihoods, which there are a lot, out of school young people, young mothers, district officers, community police officers, security agents, they all need to have access to emergency mental health support, because that's the only way they can actually, I would say, we are all going to see this crisis through effectively. And then we should make efforts to make sure that those that are isolated have access to some digital support, but not just digital support. There are some countries that are somehow, obviously making provision of mental health services an essential service, and they're making sure that nurses, community mental health nurses, are actually being able to go to homes and deliver medications, or help out with connecting people to consultations as much as they can. And that's something that we need to do very well. And the last recommendation here is to support recovery from COVID by building mental health services for the future. So it's like a build back better mechanism that says that all of this time, mental health has been very well underfunded. We don't have as much funding across the world, across Africa. I don't think we have any country that funds from its health budget more than 3% of its total health budget on mental health. And that needs to change. This is an opportunity for us to actually make sure that changes for the better. And this lack of funding needs to be fixed now, not just in government funding, but even in development funding. So given the expected long-term impact of this pandemic, I think this is the time to remedy that inequity in funding and resource provision. We also need to improve the capacity of staff, whether they're mental health workers or non-mental health workers, across all sectors, to be able to address mental health and community health mental health services to be better resourced. And finally, just to make sure that everything that we do is evidence-based, we need to make sure that we integrate research and monitoring and evaluation and evidence-based learning to every part of the recovery effort, so that we can also use that to strengthen advocacy efforts, but much more importantly, so that we will do things that are actually not more harmful than they are beneficial to the general population. Yeah,
thank you very much indeed for that, Victor, and thank you for ending on that note of the importance of evidence-based policy making and delivery. It's what works that counts, and that's a very important message. So thank you. And that gives us a good note into which to go into. We have 10 minutes, a general discussion. I will ask all our speakers to come in at the end. So if you would, as speakers, hold the questions in your mind, and you'll have a minute each for your last thoughts. But now let's go straight into our participants on the web. And we have a question from Humph, and it's just worth bearing in mind. He wonders, what does research teach us so far? Because we know there's been research into Ebola and community-led responses to Ebola. There's been some research on the effectiveness of the various HIV/AIDS communication programs. So let's see if anyone's got any insights into that, and we'll come to the speakers at the end. Are there any more points from web participants?
Paul, if I may, I've got a question.
Yeah.
Well, 2 points actually. One, first of all, is just to remind people that in the case of Victor and Bright, there's additional details on both those fantastic organisations on the interactive project map on BOBAB. So I encourage everyone here today to visit the platform, visit those project pages and give them a follow, because they're fantastic work. The other point is really an open question to the panel, is do we think that the COVID-19 could in some way act as a catalyst for speeding up the policy change around mental health? We've seen quite clearly, quite starkly, the comorbidity that can exist between mental health and infectious disease, such as coronavirus. Do we think this is at least something good can come of it, in that it can act as a bit of a wake-up call for governments and policymakers to give more attention to mental health in the public health space? And yeah, your opinions on that would be great.
Thank you very much. Any other questions or points?
You've got one from our side, which is that have any of you experienced treating clinicians, so frontline healthcare workers who've been suffering the consequences of mental health? And could you maybe talk through specific sort of tangible mechanisms or support mechanisms you could recommend to clinicians facing some form of PTSD? And the other question is, for patients who have recovered from potentially severe COVID, we've heard cases anecdotally on our side of patients really struggling after being under sedation for so long, the stigma that they're worried they'll wake up with. Have you got any specific examples again there of support mechanisms and things you talk them through? And I know we've also got Alex Royer on the line, who Victor, you mentioned, I think it's actually Bright, you mentioned Wazi, so he's also on the line, so I'd invite you to chip in with your experiences, Alex, too, if you've got any.
Alex?
Hi, everyone.
Great.
I put you on the spot, sorry.
That's all right, thank you, and thanks for all of the presentations. Really enjoyed hearing from everyone. Sorry, I have to put Slack on mute. Yeah, it's been an interesting ride, I guess, since COVID. We run a digital mental health company called Wazi, and we connect people with practitioners of all sorts. And since COVID, we've actually been having more conversations with government, which is great. We've, for the first time, heard that government is interested in supporting some of their programs at a larger scale. And so we're really interested in seeing where this goes. We've not historically been partnered with government before, and as a number of the participants called out, government is crucial to participating in this conversation. So really excited to see where this goes.
Thank you very much indeed, for Alex. Interesting that you're getting responses from government now, because the reality is that there are very few African governments who are spending the AU recommended part of their budget on health or public health. And mental health gets a tiny proportion, as Victor indicated, of that. So that if governments are going to be prepared to spend more on mental health and on health generally as a result of the COVID crisis, that must be a good thing. And I just throw into the pot for any reflections from our speakers. What is the role of private philanthropy in all of this? I mean, Victor, you've recruited this number of volunteers. That didn't just happen. People must have given resources to enable you to do that and to support the volunteer effort. How do we reach out to these philanthropists who do exist in Kenya, in Ghana, in Nigeria, people who do have money and who are giving? How do we get them to give more to health and to mental health and to civil society on the continent? How do we in Africa mobilize better our own internal resources rather than constantly looking outwards for support and assistance? That's a point I leave with you. And I think unless we have any further questions or contributions, no.
I think we have one more question in the chat, sorry, from, one more question in the chat, or two more. So one is a question for Victor specifically, which echoes one that I asked, but how do you ensure that counselling and support you provide for healthcare workers and patients is beneficial? And what does the follow-up process look like? And the second question from Gideon, who has asked, what is the role of medical diaspora communities in supporting this pandemic?
Good. And Rock's point too about breaking the taboo of mental health. I mean, it's not just in Africa that mental health has been a taboo subject. I mean, I've been a minister for mental health in the UK, and I can tell you it's only recently that we've seen any real progress in getting mental health up the agenda. And that took prime ministers getting involved, it took the royal family getting involved, it took celebrities getting involved, the Archbishop of Canterbury, all saying, look, I've had to wrestle with these problems. How can we deal with it as a community? How do we break down those taboos? So thank you, Rock, for that important point. Now we're going to go straight back into our speakers. I'm just going to come to them relatively randomly. If we can begin with you, Dr. Naimuti. Linda, your final minutes summing up. Any point you want to make as you go?
All right, so someone who mentioned about the policies, how we can push for that. And I think we need, in as much as we may have very good policies, goodwill from the government is very, very important, because otherwise you can tailor your very good bill. We have a mental health bill in Parliament, but it's stayed there for a very long time. So goodwill from the sayers is very important. When it comes to clinicians and the psychological support, currently in Kenya, we have a training that's going on for providing psychological first aid to frontline workers. That's particularly just for the doctors, the nurses, and anyone else who's dealing with on the front line, basically. And one important thing is you have to notice, in as much as we talk about stigma in the community, there's also stigma within the healthcare system that non-mental health professionals have stigmatized towards mental health generally. So that's also something that we also face as a challenge. And the medical diaspora, I don't know really, because it's a pandemic, it's a global pandemic. So it's very difficult to tell someone who already has a broken limb to come and help you also, because, but I mean, where they can, it should be very beneficial, particularly for the countries that are on their recovery phases now, like they've gotten back to their feet. To be nice if they have extra support to also help those who are crippled at the moment. Thank
you very much indeed for that, Linda. You know, you make a you make a very important point about the role of politicians in this, and you call for their goodwill. And you know, I've got something to share with you as a politician. You know, we're full of goodwill, but there's a saying from an American jurist, Black American jurist, son of a slave, called Frederick Douglass. He said, "Power concedes nothing without a demand. It never has, and it never will." Power concedes nothing without. So we can hope for goodwill, but I think civil society has to organize. We're talking about Burundi elections. You know, it's got to become an election issue. Health has to be an election issue.
Yes,
if people get re-elected, they should be prioritizing health, and mental health is part of that. But very, very important point, Linda. Thank you for making it. Nick, Dr. Bass, Nick Bass.
Yep.
With us. Great.
Thank you very much. To pick a couple of points there, the first one was about stigma and how to overcome this. I would suggest that the example we have from Uganda is engaging the community at grassroots level. So getting, engaging with community leaders, and as you mentioned, leaders, imams, these are really key people for helping to combat stigma attached to whatever it may be, mental health problems, HIV, COVID-19, TB, all sorts of things that are associated with stigma. And if I may also pick up on one other interesting question that you raised, and that was how to direct private philanthropist donors to make the best use of their donations. May I respectfully suggest that anyone who is going to do this should spend a little bit of time on looking into what actually already exists and where the gaps are, and to make sure that any donations go towards plugging those gaps, but most importantly, to support the existing health systems and strengthen them, and not do something to work in parallel to or undermine existing systems. It needs to be part of a joined up and coherent effort.
Such a powerful point upon which to end, because we all know that the history of African and global development is littered by well-meaning philanthropists who followed their own particular path and not actually supported the building up and the strengthening of capacity on the ground for whole systems approaches to healthcare. So thank you very much for that, Nick. Tarisai.
Hi, Paul. I think I want to agree with Hugo when it comes to evidence-based interventions. That's very important. I think we can take advantage of research right now and learn from what has been done before. I mean, in Zimbabwe, we've worked in the HIV sector, where we've treated depression to improve adherence. So I think this is something that we can actually build on. And also the role of other players like the community leaders, the church, because we know that when it comes to mental health, we are not the first port of call, the practitioners. People will go to the church. So I think we need to engage everyone. We need to be able to work with teachers as well, because they're with the children and adolescents. And lastly, I think thinking ahead about mental health, what COVID has done is to expose that we really cannot talk about mental health without addressing other issues. So in countries like mine, where social distancing or locking down might not work, let's work together to provide food security and shelter as well.
Thank you so much. And thank you for making that key link between food security and shelter and mental health, because people are stressed by a whole heap of things, and there's nothing more stressful than not knowing where the next meal comes from. So thank you, important point. Bright Chitemi.
Yeah, so I'll speak on two issues. Number one is how do we look for more involvement of private philanthropists. So in Kenya, we found that most of these private people, philanthropists in the private sector, with businesses in the corporate world. And what we've been doing is, with good feedback and success, is we've been taking the mental health message to corporates. As usual, we pride ourselves with using art, which is a very powerful tool to talk about stigmatized issues. And what we've seen is a huge involvement from the private sector, who've been coming in to support our initiatives and also opening up the conversation in their own companies, which has been very positive. The other thing is on the helpline, on the frontline workers being medical professionals. I would say the Ministry of Health in Kenya has been quite progressive. Why? Because apart from what they've had in store in terms of psychological first aid, we had a recent approach from the ministry to offer physical wellness as a way to approach the mental health issue holistically for the frontline workers. And that means offering yoga and dance, physical activities and also to enhance social connections among frontline workers, which is a very holistic and progressive way to address the mental health issue. Thank you.
Well, thank you, and thank you for ending with a focus on the needs of frontline workers. We all too often, they bear the brunt, and the link between healthy bodies and healthy minds and physical exercise and support for them, I think, is a very important one indeed. Victor,
right,
Nigeria.
Thanks. Yeah, I think the question I'm going to focus on, just a couple. I think COVID presents a very decent opportunity for us to advocate for increased investment in mental health services towards to the government. And what I can see is I've seen increased coordination from local NGOs to collaborate and increase their voices, and that's something I hope continues. So I think this is, like you said, an opportunity for us to actually to look at ourselves and see how we can collaborate and increase the voice and increase our asks, basically. Hopefully that yields something tangible that can actually benefit us going forward. I think that was your question, Nick. In terms of like philanthropy funding, I wish, Paul, I wish we were right that we actually got funding, but we didn't actually. So one thing that we have gained over the past 4 years is we've gained increased social capital that is quite easy for us to actually get volunteers if we wanted them. So when we made an announcement for volunteers this time, I think it lasted for just a month, and we got more than 600 applications, and we did interviews and made sure they fit into our specifications. You have to be a healthcare worker, you have to be a psychologist or something, a psychiatrist. We made sure they fit into those specifications before we proceeded to do a training for them. And I think this fits into the question that someone asked about assuring for beneficial services to healthcare workers and to frontline workers and to people that we counsel. We do an intensive and extensive training of our counselors to make sure that they're well equipped to handle all the cases that come their way. But we actually exist so that we can easily refer them to much more specialist services as needed. So we don't take on all the cases that we get. We take on cases that we can handle, but the counselors are well equipped with resources to refer to places and to services that offer much more specialist services. So that's essentially how we ensure that happens. I think those are the questions I have from my end.
Well, thank you very much indeed for that, Victor, and thank you for drawing our attention to the importance of social capital and building a reputation and grassroots crowdfunding and volunteering. But I think it's important that we make sure that with events like this coming together, thanks to Medicus and BOBAB, that we spread the word and that the people with resources and with money out there on the continent do get an insight into what's being done and what could be done with their help and support, because you deserve support. And we know the resources are there. I think we want to say a big thank you to our 5 speakers, to Linda, to Nick, to Teresa, to Bright, and to you, Victor. We want to say a big thank you to our co-producers, Bobab and Medicus, to Nick and to Nicole, to remind everybody that next Tuesday we'll be looking at the issue of business unusual, ensuring continuity of care with remote working. So the conversation continues and will continue for the next couple of weeks and beyond on this platform. And let's end on a humorous note, actually, that came to mind when I was listening to Brighton, thinking about Victor's work in Nigeria and the dynamism and the sort of humor that always exists in Nigeria. And remembering what Nick was sharing with us about the importance of masks, there's a wonderful WhatsApp, if you haven't seen it, of a particularly creative approach to making your own masks. And if you haven't seen it, I'm going to send it to Nick so he can share it with you. But it just lasts a minute or so. A Nigerian couple, a very strong-minded Nigerian woman and her partner, they get into a taxi. The taxi driver, like all taxi drivers, is challenging and difficult, and he demands to know where their masks are. There's a conversation between the Nigerian woman and her partner. And the Nigerian woman takes a very creative approach to producing a mask for herself and her partner. If you haven't seen that WhatsApp, I recommend it to you because it's a wellspring of Nigerian creativity and innovation. They represent there the African personality of triumph out of adversity. That's our theme here on COVID-19 Exchange. Thank you all very much for participating. Until next Tuesday. Bye-bye.
Thank you.